I'm hot-blooded, I'm hot-blooded, hot-blooded.
We're doing ultrasound guided procedural access. Dr. Kubi is using a high frequency linear array.
There's like a peripheral, a smaller one.
She visualizes the vessel, the target, in the middle of the screen. She then gets the needle and she is going to, in an out-of-plane technique to try to cannulate this vessel, she's going to present the needle underneath the probe. It'll appear as a hyperechoic structure in the near field. She can see that she's on plane to hit the target. She then changes her angle to a more acute angle, trying to use Pythagorean theorem to see how deep the vessel is. On these centimeter marks, it looks like it's at 1 centimeter. She will then start to advance the needle until she sees the hyperechoic needle tip, which is right here. She then moves the probe distal from her, and then she advances the needle tip into the field of view. And this way, it's always keeping the needle tip in the plane. She then will aspirate to confirm that she has successfully cannulated the vessel. This is the short axis approach. The key points are centralized, putting the image in the center of the screen, presenting the needle in the near field, then changing the angle acutely, and then advancing the probe out of the field of view, and then putting the needle tip into the field of view, and following that successively down toward the target. The key points are centralized, putting the image into the center of the screen, presenting the needle in the near field, then changing the angle acutely, and then advancing the probe out of the field of view, and then putting the needle tip into the field of view, and following that successively down toward the target. We can move the probe into a long axis view, visualizing the target in long axis. When you wear a oblique to it, it looks like a cigar shape, has tapered edges. When we're in the long axis, it looks like a tube with the vessel going all the way across the image. When she does this, and she can also see the hyperechoic anterior and posterior wall, she knows she has a specular reflector. She is at the widest portion of the vessel. She's not creating a cross-cut artifact. She then can present her needle along the long axis plane and watch her needle tip the entire way. And so up on the screen you will see the needle tip coming in the near field, and then as it passes into the vessel, the hyperechoic needle tip. This is in plane, or in the plane of the ultrasound beam, versus the short axis was out of plane.
We'd go like this. So this is the short axis for venous access. As you can see, your vessel appears as a circle. You can assess whether it's compressible by applying pressure with your probe. You should hold the probe in your non-dominant hand and brace your hand on the patient's skin, as I'm doing with my 4th and 5th digits. Place the needle just under the surface of the skin in the middle of my probe, which should correspond to where my vessel is. Once I've identified the tip of my needle, I will slide the probe away slightly to move the ultrasound beam out of the plane of my needle. I will then take a more acute angle and advance my needle.
I'm hot-blooded, I'm hot-blooded.